Okay, good morning, everybody. It's a great pleasure and a great honor for me to be here. And I would like really to thank everybody and the organizers of this wonderful meeting for having me here. It's my first time in El Salvador, and it's a great pleasure and great honor. So the topic that I got was, is it functional hypersensitivity or reflux? Now, the way I interpreted this topic was, is it functional heartburn, reflux hypersensitivity, or gastroesophageal reflux disease? Now, I was one of the lucky people to be part of Rome 4. As you could see, I was the chair of the functional esophageal disorders of Rome 4, and you can see the other members of my committee. I'm also lucky to be a member of Rome 5. I don't know if you know, but don't get comfortable with any of the definitions I'm showing you, because Rome 5 is coming your way, and I'm sure there are going to be some new changes as well. But one of the things that I'm most proud of from being the chair of Rome 4 is the introduction of reflux hypersensitivity, which was not without a lot of tears, blood, and sweat. A lot of concerns about the introduction of reflux hypersensitivity as a new functional esophageal disorders. What I want to show you here is that as part of functional esophageal disorders, we have two that have the same predominant symptom, which is heartburn. This is functional heartburn and reflux hypersensitivity. It is the first time that in our functional esophageal disorders, we have two disorders with the same predominant symptom. Now, functional esophageal disorders are part of disorders of gut-brain interaction, and they are defined, the functional esophageal disorders, as chronic esophageal symptoms in the absence of identifiable structural, inflammatory, motor, or metabolic mechanisms as the etiology. Now, this is the definition of functional heartburn. It was defined by Rome 4 as burning retrosternal discomfort or pain, no symptom relief despite optimal anti-secretory therapy. You cannot have any evidence of gastroesophageal reflux and no evidence of eosinophilic esophagitis. And in addition, you should not have any evidence of what we called at the time major esophageal motor disorders like achalasia, EGJ outflow obstruction, jackhammer esophagus, and absent contractility. I can tell you that now we don't have any more in Chicago 4, and I was lucky enough also to be part of Chicago 4, part of the EGJ outflow obstruction section there. And as part of the Chicago 4, all disorders are going to be major, including ineffective esophageal motility. So the future of Rome 5 would be to include also the others. And the criteria must be fulfilled for the past 3 months with symptoms onset at least 6 months before diagnosis with a frequency of at least twice a week. Now, what is the definition of reflux hypersensitivity, which was introduced, as I mentioned, for the first time by Rome 4? Retrosternal symptoms, including heartburn and chest pain, normal endoscopy, and absence of evidence that EOE is the cause of symptoms, no evidence of a major motor disorder, and then evidence of triggering of symptoms by reflux events despite normal acid exposure on pH or pH impedance monitoring, and response to anti-secretory therapy does not exclude the diagnosis. And again here, criteria must be fulfilled for the past 3 months with symptoms onset at least 6 months and with a frequency of at least twice a week. Now, you all know that there are 3 GERD phenotypes. These are the basic phenotypes of gastroesophageal reflux disease. We have non-erosive reflux disease that account for 60 to 70% of the patients. We have erosive esophagitis that accounts for about 30% of them. And we have Barrett's esophagus, which is between 6 and 8%, some say up to 12%. But the biggest group, the biggest phenotype of gastroesophageal reflux disease is non-erosive reflux disease. N1, and I would like to emphasize that. And if you remember this one sentence I'm going to say now from my presentation, then I did my job today, and I'll take the next plane today back to the US. If you remember that part, one cannot separate among any of the GERD phenotypes and any of the functional esophageal disorders that I just mentioned, functional heartburn and reflux hypersensitivity, by patient symptom presentation, severity, frequency, or duration of symptoms. One cannot guess what the patient has based on any of those typical symptom domains. And that's very important. And when it comes to separating between GERD and the other functional esophageal disorders, our focus is primarily on non-erosive reflux disease, because endoscopically, they have the same presentation as functional heartburn and reflux hypersensitivity. Now, what are the definition of non-erosive reflux disease? It's amazing to me that even today, we're still relying on very, very old definitions, which I was, by the way, lucky to be part of both of them. And I think it's time to change them, because when I read you the definitions that we currently have for non-erosive reflux disease, you will see that they are not great anymore. At the time, they were nice and good, not anymore. So the Montreal Consensus meeting, which, by the way, did not take place in Montreal, it took place in Rome. And they called it Montreal is because they didn't want to call it the Rome Consensus, because we already have a big Rome. So Montreal Consensus is non-erosive reflux disease is defined by the presence of troublesome reflux-associated symptoms and the absence of mucosal breaks. That's it. That's the definition. And when you look at VEVI Consensus, it's a subcategory of GERD characterized by troublesome reflux-related symptoms in the absence of esophageal mucosal erosions breaks at conventional endoscopy and without recent acid suppressive therapy. Well, the advantage is that they say that the patients have troublesome reflux-related symptoms, but they don't tell us here anything in how to separate non-erosive reflux disease from the two functional esophageal disorders, reflux hypersensitivity and functional heartburn. It's the biggest problem today that we have with the non. So these definitions are not great definitions, but that's what we have. Now, if you have a patient that presents with heartburn as their predominant symptom, and you do an endoscopy and the endoscopy is normal, the major or most of the underlying medical problems that can lead to that, not all of them admittedly, are non-erosive reflux disease, reflux hypersensitivity, or functional heartburn. About half of the patients have a risk of having non-erosive reflux disease, 20% reflux hypersensitivity, and 30% functional heartburn. Now, they could have eosinophilic esophagitis, they could have other disorders, rumination and others, but we assume that you were able to rule the other ones. Now, when you have patients that present to you with heartburn and they undergo, and they haven't been worked up, and they undergo an upper endoscopy, about 30% of them will have erosive esophagitis, and about 70% of them will have normal endoscopy. If you take the patient with normal endoscopy and you do a pH test, about half of them will have an abnormal pH test and the other half normal pH test. Those half with normal abnormal pH tests are the ones that have non-erosive reflux disease. But we still have another half that have a normal pH test. When you look at symptom indices in these patients, you will find out that about 40% of them have positive association between their symptoms and patients' heartburn and reflux events, and these are the reflux hypersensitivity patients. And then you have another 60% of these patients that show no correlation between their symptoms and reflux events, and these are functional heartburn. So at the end, reflux hypersensitivity patients account for 14% of all those that show up in our office just with heartburn, and functional heartburn of 21%. Together, they account for 35% of patients that walk into our clinic with heartburn. About a third of the patients have functional disorders up front. And we might treat them like gastroesophageal reflux disease. Now, there are many things we learn over the years about heartburn. So when I started my career, it was no acid, no heartburn. Now we know that this is obsolete. This is not true. So first of all, esophageal symptoms are not stimulus specific. No acid, no heartburn is obsolete. We know that. There are different types of symptoms that may be generated by the same stimulus, even in the same patient. So you can have, we do know, for example, that mechanical distension of the esophagus, like balloon distension, which is not chemical, like acid reflux, can lead to heartburn. Heartburn can result from different intraesophageal stimuli. So the slides looks like they have a life of their own. Heartburn, and then the esophagus has very limited repertoire of symptoms. At the end of the day, our esophagus can generate very few symptoms. So the whole concept that symptoms are stimulus specific was wrong from the beginning. And then functional esophageal disorders can present solely with heartburn, which is indistinguishable from the heartburn reported by all phenotypes of GERD, including non-erosive reflux disease. And it doesn't matter how you look at these symptoms, based on their frequency, severity, or duration. One cannot just, by looking at the patient, assessing their presentation, decide, hey, this patient most likely has erosive esophagitis. However, there is a hierarchy in response to PPI when it comes to these three different patient populations, where the patients with non-erosive reflux disease appear to have the best response to anti-reflux treatment, followed by reflux hypersensitivity patients, and patients with functional heartburn at the bottom have no response, none whatsoever, to anti-reflux treatment. We also need to look at the underlying mechanisms of these three different disorders. And this was generated, by the way, by the Rome 4, this slide. And you can look on the left side, you see the two phenotypes of gastroesophageal reflux disease. In patients with erosive esophagitis, acid exposure is the main underlying mechanism. As you move to the right, you have the non-erosive reflux disease patient. There still, acid exposure is the main mechanism, but we start to see another important mechanism, which is esophageal hypersensitivity. As you move further, you will see the patient with reflux hypersensitivity, where in these patients, esophageal hypersensitivity is the main underlying mechanism, but still there is a component of acid exposure. And as you move to the functional heartburn patient, it's only esophageal hypersensitivity. What is esophageal hypersensitivity? Esophageal hypersensitivity is the perception of non-painful esophageal stimulus as being painful, what we call allodynia, and normally painful esophageal stimulus as being more painful than usual, what we call hyperalgesia. And this was studied using a variety of intraesophageal stimuli, mechanical, thermal, chemical, and others. So how do I differentiate from a diagnostic point of view between these or among these three different disorders? So let's look in patients with recurrent heartburn despite PPI therapy without previous evaluation for gastroesophageal reflux disease. The patients are treated with PPI, they're not responsive, and you want to know which of these disorders are giving the patient these continuous symptoms. So these patients should undergo endoscopy with biopsies in order to rule out eosinophilic esophagitis. Now, eosinophilic esophagitis is very unusual in presenting only with heartburn. it's usually presenting with dysphagia. But there are studies showing that in some of them, including one from Brazil, up to 8% can present only with heartburn. So you have to rule it out. If the endoscopy is negative and the biopsies are negative, then the patient should undergo reflux testing, and it should be done off PPI therapy because we don't have any evidence that the patient has gastroesophageal reflux disease. So we have to stop the PPI. Preferably, the patient should undergo a pH test alone. I don't know how much, if you have availability for the Bravo wireless pH capsule. If you don't, then you can do the 24-hour pH test. If you have only the pH impedance will work, but it's preferable to do the Bravo or the 24-hour pH test. If it shows excessive acid exposure, then you have your answer. The patient has non-erosive reflux disease. If they don't, then you look at symptom association. But before you conclude anything, you have to do esophageal manometry to rule out major esophageal motor disorder. Now, if you rule that out and the patient does have an association between their symptoms and reflux events despite normal endoscopy and normal pH, you have your reflux hypersensitivity patient. If they don't, then you have your functional heartburn patient. How do we make a diagnosis of these disorders, especially functional heartburn and reflux hypersensitivity, in patients known to have gastroesophageal reflux disease? So the patient is not responsive to PPI. We do know that they have GERD because they've had endoscopy in the past and the endoscopy showed erosive esophagitis, or if they had a normal endoscopy, somebody did a pH test and it was abnormal. So they do have documented GERD. So we don't have now any argument about what we have. The question is, despite treated with PPI, they're still having symptoms. Could it be an overlap with these two functional esophageal disorders, reflux hypersensitivity or functional heartburn? The same kind of protocol, it's just that here the reflux testing is pH impedance done on PPI because the patient is known to have GERD. We're not looking to see if they have GERD. What we're looking to see is if the PPI double dose still control their reflux, and then if weakly acidic reflux, which is picked up by the pH impedance, is the underlying mechanism for their residual symptoms. And again, you can make the diagnosis of reflux hypersensitivity and functional heartburn. Don't forget to do esophageal manometry first to rule a major esophageal motor disorder. The Lyon consensus changed a few things in my mind. They may affect on how we separate between functional heartburn, reflux hypersensitivity, and non-erosive reflux disease because they change some of the definitions. If you look at the top, this is the consensus meeting about new metrics for diagnosing gastroesophageal reflux disease that was done in Lyon, France. And if you look at the top, they call it conclusive evidence for pathological reflux. They said that in endoscopy, if the patient has Los Angeles grade C and D, long segment Barrett's or peptic stricture, they do have GERD, conclusively. If they have A and B, it's inconclusive. Look at below. Now, we can argue about it. I personally think that that's a mistake. And I know that they're going to be, for them, it's another excuse to have Lyon 2. They like Bordeaux as they speak about new definitions. But I'm sure that they will change it because they got a serious backlash about this kind of concept. The other concept is also they changed the diagnosis of what we call non-erosive reflux disease by moving the abnormal pH from 4.2% to 6%. That really expand the number of patients now that can fall under the category of functional heartburn and reflux hypersensitivity, clearly, because now you need to get 6% and above to be called non-erosive reflux disease. Now, how do we make a diagnosis of non-erosive reflux disease versus functional heartburn and reflux hypersensitivity? I'll show you some of the tests that have been mentioned in the literature. Most of them are not used anymore, but they're still, I see them still coming up in papers. One of them, for example, is high magnification endoscopy with NBI, narrowband imaging. The suggestion is that if you do that and you see, for example, increase vascularity at the Z line, like it shows here, then it's most likely non-erosive reflux disease. If you see others, then it's most likely not non-erosive reflux disease, or microerosions, it's more non-erosive reflux disease. I can tell you that today, most of the people do not make diagnosis of non-erosive reflux disease based on that, but you're still going to write it. You're going to read about it. What about histopathological analysis? So using the typical, so you take biopsies from the esophagus and you try to make a diagnosis if the patient has NERD versus a functional disorders. So what about all these typical GERD-related changes like papillary elongation, basal cell hyperplasia, and others? And in this paper, they even came up with what they call SUM score, which includes all these pathological abnormalities. Well, now we don't use that often because we know that a lot of them can also appear in patients with eosinophilic esophagitis. There's a lot of literature. We are bombarded about the use impedance pH metrics, like the PSPWI and the MNBI. I'm not going to spend the time because it's just going to take a few more minutes in order for you to understand what they mean. About the MNBI, which is the mean nocturnal basal impedance, it is just by when you do impedance tests over a period of 24 hours, the impedance tests measure the baseline impedance of the tissue in the esophagus. And that can tell you if the patient has reflux or doesn't. In fact, if it's above 2,292 ohms, then it's most likely functional heartburn. And you can see that there are different numbers for non-erosive reflux disease, hypersensitive esophagus, which is another name for reflux hypersensitivity. Now we think it's 2,000 ohms. The number has been set yet. But this is only if the patient undergoes impedance plus pH. You can use those metrics. It's one of the options we have. Mucosal impedance, we are using it. It's proved in the US. And that allows us that during endoscopy, instead of doing 24-hour pH impedance, when we do endoscopy, we put a probe in and we measure on the spot the mucosal impedance, basal impedance. And based on the number we get, we can actually decide, placing this number on this figure on the right, we can decide if the patient has functional disorder or GERD. We cannot decide which functional disorders they have. If it's reflux hypersensitivity or functional, we can just separate between the two, functional esophageal disorders or GERD. Probably available, this type of technique, in about 4 or 5 centers in the US. So how do we treat the 3 different disorders? In the case of non-erosive reflux disease, this is the treatment paradigm, lifestyle modifications, anti-reflux, OTC anti-reflux medications, Gaviscon, Carafate, H2 blockers, PPIs, endoscopic treatment, and surgery. One of the things that is very important about non-erosive reflux is because we do know that these patients are unlikely to progress over time to erosive esophagitis or Barrett's esophagus, is the fact that they can be treated on demand. And there are studies looking at PPIs on demand. The only thing is that PPIs are not good on-demand drugs. On-demand means that patients take the PPI whenever they feel they like it, for the duration they desire, and they're not allowed to take more than 1 PPI per day. So usually they take it when symptoms trigger that. Now, there's going to be a new class of drugs, which in my mind will completely revolutionize the landscape of gastroesophageal reflux disease or all the acid peptic disorders, which are the PCABs. And I can tell you that, and it's already, because it's already out there, at the session, I will present for the first time in the US the role of PCAB as an on-demand treatment in non-erosive reflux disease. And it works fantastically because PCABs have an immediate effect on intragastric pH, unlike PPIs. Now, studies have shown that patients with non-erosive reflux disease, in general, we were told that their response to PPI is less than patients with erosive esophagitis. However, when you compare specifically patients with erosive esophagitis versus those with non-erosive reflux disease that were studied and are shown to have abnormal pH tests, there is no difference in their symptom response rate between the two. The reason why we saw the difference in the previous studies, because these were pivotal trials, large pivotal trials that were done for approval of all kind PPIs. These studies did not specifically do pH tests to ensure that all those that have heartburn and normal endoscopy also have non-erosive reflux disease. Now we know that they could include functional heartburn and reflux hypersensitivity. If you exclude the functional heartburn and reflux hypersensitivity, the response of the true NERD patients is similar to patients with erosive esophagitis to PPI. Obviously, when it comes to non-erosive reflexes, it depends on what clinical endpoints you're going to use. If you're going to use a tight clinical endpoint, like you have to see complete resolution of symptoms during the last week of treatment, then you will see a relatively non-impressive results, like here, 30, 40%. If you loosen the clinical endpoint and you say heartburn-free days during the 4 weeks of treatment, then it will go up to 70%. Depends what clinical endpoints you're going to use in your study. And by the way, you can play with these clinical endpoints to impress the clients. It's one of the things I always, when I sit with drug companies and they look at study design, I show them this and I say, you can actually decide how impressive your drug could be based on the clinical endpoints you're going to use. All the studies for non-erosive reflux disease are done for 4 weeks because we're not looking at healing of the esophageal mucosa. But as you can see, we don't know what happened after 4 weeks because we see that there is increase in response from 1 week to 2 weeks and 4 weeks, and then it stops. And it stops because nobody did studies beyond 4 weeks. It could be that if it goes higher, it could be plateau or it could be going down. We don't know. These are the AGA clinical practice update that I wrote for functional heartburn. That was published a couple of years ago in Gastro. PPIs have no therapeutic value in functional heartburn, the exception being proven GERD that overlaps with functional heartburn. Neuromodulators, including tricyclics, SSRIs, tegaserod, H2RA, and can be used as primary therapy in functional heartburn or add-on in patients with an overlap. Acupuncture and hypnotherapy can be used also as sole therapy or in combination with therapeutic modality. And anti-reflux surgery and endoscopic GERD treatment modalities have no therapeutic role in functional heartburn. You can see here the 3 studies, 3 randomized controlled trials that were done in functional heartburn using imipramine, fluoxetine, and ranitidine, an H2 blocker. And all of them were positive, except one, the imipramine. And this is a study showing that melatonin works well in patients with functional heartburn. In fact, it worked better than nortriptyline. What about, this is the proposed treatment guidelines for reflux hypersensitivity that we recently published in the esophagus textbook, that PPIs have a therapeutic value in reflux hypersensitivity, regardless if it overlaps with GERD, because patients with reflux hypersensitivity do respond to PPI, although less than GERD patients. Neuromodulators like TCAs, SSRIs can be used as primary therapy or as an overlap. Acupuncture and hypnotherapy may be used as sole therapy or in conjunction in case of overlap. And anti-reflux surgery, but not endoscopic GERD treatment modalities, may have a role, a therapeutic role, in carefully selected reflux hypersensitivity patients. In fact, this is the study that supports that. That study, the title of the paper is Reflux Hypersensitivity is not contraindicated in Nissen fundoplication. And in fact, they showed that patients with reflux hypersensitivity did as well as NERD patients post-fundoplication. As I said, when you do surgery on functional esophageal disorder patient, you have to be very, very, very careful. And here are the 3 randomized controlled trials in reflux hypersensitivity. Citalopram and fluoxetine were positive. The imipramine was negative. Always remember psychological intervention when it comes to all of these 3 groups. Always remember that. And there's now a lot of information about esophageal hypervigilance and its role. And these are a variety of psychological intervention can be used in these patients. If you want to get more information about what I just said, this is a paper I published last year in Nature Reviews. It's a Nature paper, and you have, this is the first review that covers all, on GERD, that covers all the way from pediatric to older patients. And in 2 or 3 months in the New England Journal of Medicine, I wrote their clinical practice for GERD, and you can see that if you want to further expand of what I said. Thank you very much.